epidemiological factors and predisposing conditions. Squamous cell carcinoma and adenocarcinoma of the esophagus share some risk factors, whereas other risk factors are specific to one histologic type or other. Tobacco and alcohol. So, tobacco and alcohol use are considered the major contributing factors in development of esophageal cancer worldwide. It is estimated that up to 90% of the risk of squamous cell carcinoma of esophagus in Western Europe and North America can be attributed to tobacco and alcohol use. Population based studies demonstrate that tobacco and alcohol use are independent risk factors and their effects are multiplicative. As evidenced by association of the highest risk of developing esophageal cancer with heavy use of both agents, approximately 65 to and 57% of the squamous cell carcinoma of esophagus have been attributed to smoking tobacco for longer than 6 months in Caucasian and African American men respectively than in the United States. So there appears to be a dose response effect related to the duration and intensity of smoking, and importantly there is an impressive up to 50% reduction in the risk of developing squamous cell carcinoma of the esophagus in those who quit smoking, and an inverse relationship between risk and the length of time since cessation of tobacco use. Cigarette smoking in adenocarcinoma of the esophagus leads to a twofold increase in the risk for ever smoker and dose response effect related to the number of smoking pack years and increased risk. Quitting smoking does not appear to confer the same degree of reduced risk of adenocarcinoma as is seen with squamous cell carcinoma, and the risk remain elevated for decades after smoking cessation. This suggests that tobacco carcinogen may affect as a carcinogenesis early on its esophageal adenocarcinoma, and therefore the decline in prevalence of smoking in United States has not had an impact on the risk of disease. Consistent with this hypothesis, cigarette smoking was identified as a risk factor for development of the Barrett esophagus. Specifically, when analyzing data from 5 case control studies involving 1059 patients with Barrett esophagus, 1332 patients with GERD, and 1143 population based control, patients with Barrett esophagus were significantly more likely to have ever smoked than either control cohort. 1.67 versus odds ratio of 1.67 versus population based control, odds ratio of 1.61 versus GERD control. So increasing the pack years of smoking increase the risk of Barrett esophagus. Alcohol is a major contributing factor in increased risk of esophageal squamous cell carcinoma in Western countries, likely accounting for 80% of the squamous cell carcinoma of the esophagus in men in the United States. A dose response relationship exists between the amount of alcohol ingested and the risk of developing squamous cell carcinoma. In many studies, the most commonly consumed beverages in a specific geographic region is the most frequently associated with increased risk. Although specific carcinogens may be present in a variety of alcoholic beverages, in all likelihood, it is alcohol itself, either as a mechanical irritant, promoter of a dietary deficiency, or a contributor of susceptibility to other carcinogens, that leads to carcinogenesis. Large population-based case control studies in both United States and Australia revealed no relationship between alcohol intake and the risk of esophageal adenocarcinoma.